Good morning, everyone, and welcome to Las Vegas, or virtually. I'm going to do the introduction for Dr. Mikhail Snyder. He is the founder and chief executive officer of Nightingale Education Group, a mission-driven organization focused on innovative healthcare, workforce development across entire professional continua. From certificate programs to graduate studies to reskilling and upskilling through continuing education, from 2012 until 2023, Snyder served as the first president of Nightingale College, a higher learning institution dedicated to closing equity gaps and creating geographic, socioeconomic, and demographic access to the nursing profession, creating thousands of new nurses throughout the United States. A visionary leader and a registered nurse for almost 30 years, Snyder has a wealth of management experience in post-secondary education for health professions and healthcare delivery services. He is a published academic author, conference speaker, and guest lecturer specializing in strategic planning, organizational development, forecasting, and management. Snyder holds a Master's of Business Administration degree from University of California at Berkeley Haas School of Business. In 2024, he was awarded an honorary doctorate in Nurse Education, Leadership, and Innovations. Dr. Mikhail Snyder.
All right, well, good morning, everybody. Good afternoon, those of you in the East out there, where it's bright and early for us here, so that's great. It's even earlier in Alaska. Imagine that. All right, so thank you all for gathering. Those of you, a couple of notes for those of you in the cyberspace. We will be taking attendance throughout this, so pay attention to Brianne, where is the questions going to go into?
It's a forms question in the chat.
It's a forms questions in the chat. So like when you see a question pop up and it's going to be pinned to the top, just click and answer all of this. Lucky all of you here, you don't need to do that. Yay! We're gonna have us a 3D interaction, which is great. So also a couple of notes. We will have a break. Worry not. So we'll go for about an hour and 10 or so, and then we'll break, and then we'll come back and wrap it up. Here in the Pacific time, in a very balmy Las Vegas, we will be out by about 12:30. Okay, so that. Also, today it's all about, facts, right? And facts of nursing, of healthcare, and kind of trying to figure out what it is that all of your responsibility is in changing the course of healthcare and the nursing profession in the United States. And so for the purposes of today, though, I'd like you, all of you love TV, I'm sure, or whatever your favorite source of fake news may be, right? I mean, like MSNBC or Fox. I'm not suggesting that any of them are fake. I'm just saying for the purposes of today, step out of it. Any belief that you may have from TV or from YouTube or internet, whatever, my algorithm put it there kind of thing for me to enjoy, how it works. Like we all love our algorithm, right? We enjoy, and like endless scroll, and all of a sudden it's like, oh, I do like that. Yes, very good. So today again, we're going to focus on actual facts. Right, and not sort of, what you may have heard. So, and where do we find like actual facts? What would be a good source for facts? The what? Google? No, not a good source for facts at all. Absolutely not. Not, and whatever the, the AI agent that is attached to you, not great. It can make up stuff. And whatever. So no, internet, wiki is not a great place for facts. So where is a good place for facts? Where? Well, published stuff, yes. So library you can go. You don't need to go to a physical library anymore. But facts are, yes, go ahead. Right, so statistical websites, governmental websites, because I mean, where actual facts and figures are collected. Bureau of Labor Statistics, for example, the Human Health Resources and Services Administration, HRSA. So there's those are good sources of information. In libraries, peer-reviewed journals, right? So it is, and it's very rarely that a peer review study is published and then retracted. So that happens very rarely. So people don't usually fudge the when they submit for peer review. Bless you. Yeah. Okay. So for the purposes of today, we're going to remove all of the hats, but sort of the fact hat and a nursing hat, right? Brienne mentioned in the intro that I am a nurse. I have been a nurse for a very long time. I finished my nursing school in 1991. So tells you, I was like, oh my word, like that year. Was a good year, right, for most of you. You were not around. And then I've been licensed in the States since 96 and working here since 96. So I'm very passionate about it, and that passion is what driven me to figure out and start up Nightingale to bring this education, to make it more accessible. None of it made sense to me when I first started working in education. I came from services, obviously taking care of patients and managing services. And so none of it made sense, and I decided to just like take a stick of dynamite to all of it and blow it up and see what can be rebuilt out of it. And so this is the only engagement really that I do with learners, and I do it every semester, and obviously all of you are enrolled in your first nursing course with us, right? You may, any PNs, practical nurses, vocational nurses here? No, okay, wow, awesome. So you're like fresh, brand new altogether, fantastic. Those of you practical nurses, vocational nurses out there, thank you for your service so far, and yay, for the decision to continue your education. But really it's, if you look at, supposed to be clicking, whoa, clicking through this a bit. Oh, wow. Ding, 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 ding. Hopefully this is not going to cause any kind of, do you want to see what that's all about? I tested it earlier and it didn't do this. Okay, so maybe it's a little bit of a connection there, something. Okay, well, don't breathe, anybody. No, maybe. Okay. Reset. All right, we're gonna try it again. Ta-da! Maybe. Awesome, magic touch. Yeah, that's right. Brienne, everybody. Okay. Oh, another thing for those of you in the cyberspace, what I have to mention is, by the way, I move around. I'm not gonna go past this like line here because I've been told I can't. Otherwise, I'd be floating like all over. So those of you out there, please use the chat. We are monitoring the chat, and so if you have any kind of questions or comments or anything throughout, then throw it in the chat, and then Brienne is monitoring it, and when she finds something interesting, she'll pause me, and I'll answer some questions for those folks. So first and foremost, let me ask you this question: why is health important? Is it important? Is health important? Yes. Okay. Yes. I think we all can agree on that. Why? Why is it important? What about it is important? What does it do? Quality of life, absolutely. So for an individual, a healthier individual has better quality of life, right? They can enjoy more things and it essentially can be happier and so forth when you're not constantly struggling with issues, be it physical issues or mental issues, emotional issues, whatever else. So health brings better quality of life to a person. And what else? Why else? So that's on a personal level. Why else is it's important? Is it important for a family?
Yes.
Why?
So you can care for one another.
You can care for one another. You can be together. You can, again, enjoy things together, right? And kind of have that better life together. It is important for families. It is important for communities. Why is it important for countries? Right, exactly. Absolutely. If everybody is, not feeling well, guess what? The productivity is down, everything is down, the economic output is down, and then everybody is poor. Like that, and vice versa. The more and the healthier population exists, the better the economies are. So it is a requisite, is the basic human need. Health is. And you probably, those of you who've had your general psychology, you remember Dr. Maslow there in the pyramid, right, of human needs and human motivation, which says really, health lies somewhere in those deficiency needs in the bottom, sort of the bottom portion, right, the physiology, and then safety. Belonging as well is a part of that, because that emotional wellness is a part of that, and so forth. So health is fundamentally important for human beings to flourish. All right. Before we go into anything else, I'll give you sort of the punchline of this entire thing, is that this is from the 2020 report on the future of nursing by the National Academy of Medicine. And it came out in 2021. Why? The 2020 report came out in 2021. COVID, right? Everybody remembers that? Who was in high school? Yeah, I know. Woof. I know. That was fun, right? No, not at all. It's just like we lost a lot of productivity and learning and all sorts of stuff during those years. But yeah, so this report came out in 2021, and it follows on the heels of, not quite on the heels, it's a decade after the first one was published back in 2010, and the conclusions are the same. In order for health equity to exist, now let's dig a little bit into that. I know the word equity gets a bad rap recently, with no one understanding what the heck it actually means. So what does it mean? What does equity mean? Anybody? Like, throw anything out. Like, what do you think? The what? Value, okay, there's some value in equity, yes. Like, but what is it about? How is it different from equality? Let's start with maybe with an easier one. What is equality? Being equal. But what does it mean? It's like an Oprah, right? You get a car, and you get a car, and you get or you get a bread loaf, and like that. Some of you may not know who Oprah is, but look her up. She's amazing. Anyway. So everybody gets something of the same, right? So what is equity?
Equity is you get what you are basically qualified. Like, if you have the qualifications for it, no matter what no matter what you believe in, you still get.
Well, okay. Maybe we're a little bit there. Yes.
To add what she's saying, that everybody gets the same care on both sides.
Right. So again, equal is not equitable. Doesn't mean equitable, because if I would give everybody, pick anything, right? Like, you get an apple, and you get an apple, and you get an apple, and some of you may be like, oh my God, apple. Can't stand it. It's just nasty, right? And the others will be like, whoa, yeah, great. So everybody got equal, but did you get what you needed?
So equity is when everybody gets what they need.
Very good, very good. So when people have access, whether they use that access or not, that's up to them, right? But they do have access to what they need in order to get to the same outcome or comparable outcome to everybody else, right? So if we're talking hunger, or like you're hungry, or you're, and let's not hungry, but like you're like, you know, really want a snack, and I'm giving you that apple, and it may not work for some, right? Because you may want a banana, or like whatever else you may like. I despise pears. So no matter how many pears you gave me, I will not eat a single one of them. And I will, I don't like them, right? And so yeah, and this is a simplified way to look at it, but really it's having access to what one needs in order to meet and have an outcome, meet a certain need and meet and have an outcome that is comparable to others, right? So to everybody else, not a lesser outcome, comparable outcome. Yeah, okay. So that's that. And what this study says, essentially, that this nation will never thrive until we do have health equity, meaning access for an entire population, access to the resources that one might need in order to lead that healthy life, comparable health outcomes to everybody else. And then number two there, should not be a surprise that nurses are the catalysts for that change, right? And unfortunately, we haven't been as effective in driving that forward as a profession. And we'll dig into the profession here next. And really, this is the call to action to everybody. And essentially it says that all of the systems, all of them, that regulate, educate, pay, employ, and so on and so forth, nurses must evolve, must change in order for us to get to a better outcome downstream, in order for us to get to this equitable environment where everybody, again, has access to what they need to lead that better, healthier, more productive life. Mm-hmm. When that happens, again, the economy then flourishes. We as a nation flourish when that happens. It doesn't happen any other way. And nurses have a lot to do with us like not being there, and the opportunity is for all of you, and this is the reason I do this workshop, this is the only engagement with learners I do, is to encourage you and inspire you and invite you to dedicate your career to changing this, to bringing health about to your families, to your communities, to the population at large. And so we're going to dig into it and talk about what it is that you can do, what you can do now, and then what you could do in the future in order to drive that forward. So everybody with me? Yes. Good, fantastic. All right, so let's jump in. How many nurses are in the United States? Let's take RNs. How many RNs are in the United States? Everybody's like, I don't know. Right, so there are many, but there's a shortage. Yeah, okay. But the question is, how many? Take a wild guess. What do you think? How many people live in the United States? Anybody? The what? No, not that many. Oh, oof. If we had that many people, I don't know what we would be doing. About 330, 340, like 350, depends on who's counted, obviously, in the census, but it's around that, low 300 million, 330 plus number. And so how many out of that, how many nurses?
I'd say about 1 million or 2 million.
Aim higher. 4.3 million RNs. This is licensed RNs in the United States. 4.3 million, this is well over 1% of the entire US population are RNs, right? Think about your Facebook, right? Like your 532 friends on Facebook. You really only need to reach 99, like 98 and a half to, with your nursing sort of wisdom and all of this to change this entire thing, right? And you already have 500 something, right? Like, oh, it's like she's a friend and he's a friend. I'm like, no. But mathematically, we should be just like thriving, right? With so many practitioners, we should be thriving. Now, this data comes from HRSA, and by the way, you will all get these slides after today's workshop, so like, you know, you don't need to take all of the notes. It'll be available to you, will be sent to you, to everybody. And so, but this comes from HRSA, and these are licensed RNs. It is estimated that about 3.5 million are actually, estimated by HRSA, that 3.5 million are actively working. Full-time, part-time, there's no distinction on that, but that's the total number. The Bureau of Labor Statistics estimates the working RN population at 3.2 million. So even lower, but still at that about 1% of the entire population of the United States. So many, right? And we'll dig into the reasons why there's so many of us, and yet nothing really has dramatically changed toward better outcome in a very long time in the nation. All right, so 4.3 million RNs. Speaking of the shortage, this is estimated by McKinsey. Very conservative number, we're at least 200,000 short today, like now, to about almost 500,000 short. And then this is, and also I'm putting this up here to show you that the profession does not really, culturally or demographically, it does not mirror the population of the United States. That means that in many communities where that mirroring does not exist, the outcomes are further, or better outcomes are further delayed because there is some cultural disconnect and so forth. I'll give you one example. So the number 2 preventable cause of death. What do you think that is? Number 2 preventable cause of death. Completely, fully preventable. No. I mean, car accidents are preventable, obviously, if, you know, if like Waymo drives for everybody, right? Because like our heads don't spin like Waymo does. I don't know if you've seen it here on the streets yet. I like went to California, to San Francisco the other day, and it was like, oh wow. I mean, all these cars like driving around and stopping and like doing all sorts of like, oh no, after you. But no, like the conditions that are medical conditions. The what? No, so cancer, yes, but it's colon cancer, right? Colon cancer, completely and absolutely preventable, because it doesn't start as cancer, right? It starts as a polyp, and then when polyp sits there and sits there and sits there and sits there, it develops then over time, it develops into cancer. Now with screening, you can completely avoid it. Which group do you think suffers from that, from death, because of untreatable, undetected colon cancer more than any other demographic group? Black, yeah. Black males. Black males. So, and absolutely. So there is a cultural, right, historical sort of undertones. There's also this sort of cultural, no, not around, you know. It's like, no, you're not coming around there. Not with a tube. All of that. And the black males are the least represented in the profession of nursing and in the profession of medicine. The least represented. So imagine if there's some sort of equilibrium that existed and somebody could talk, somebody who is a nursing professional, a medical professional, could talk to the community and say, hey, there's no shame, no stigma, whatever, kind of remove that stuff away, how many lives we could save, and money. Because end-of-life care is very expensive, right? And trying to treat something when it's in stage 4, and it is really, I mean, it is expensive and not as effective as before it even becomes cancerous, right? So there are many studies that are pretty conclusive on the fact that when the care is provided for the population, whatever population it may be, community, by a healthcare workforce that closely mirrors that population culturally, demographically, so forth, so the outcomes are better. The outcomes are better. When, so think of it this way as well. There is only, this doesn't say it, but the proportion of males in the nursing profession, it's only about 11. Only about 11%. I mean, again, it depends on what study you look, but it's very small compared to the proportion of female practitioners. And so there's no mirroring in that, right? There's no gender mirroring in the profession either. And unfortunately, thank you guys for, 3 of you, yay, for choosing this as your professional path. But getting more males into the profession is part of this quest to get a better, better balance, better mirroring, and get better outcomes as well. So that's yeah, we're not doing that hot, and we have a long way to go to get to true kind of balance and mirroring, which will affect access and will affect equity and will affect outcomes at the end of the day. So, but yeah, we're very, very short. So for now, any of you who are choosing to go into this profession, thank you. Yay, we do need you. But we need you to be active as well, right? Not just like, oh, okay, I got my license, and now, let's see what's next. Ooh, Prada, of course. Like first paycheck, shoes. I don't know, like whatever it is for you. But and that's great, and you will absolutely improve your economic position and your family's economic position, and that's fantastic. That's great for you. Now, after you do that, also staying engaged and driving these outcomes forward, and remembering that you have a deeper a purpose. Exactly, very good. Deeper purpose in this, what you do. All right, so a couple other things. This is a 2023 study that in 2023 projected that within the next 7 years, and this is 5 years from now, 1 million will retire. 1 million. And we are really rapidly on our way to a situation that it is even worse than what we have today. So producing as many nurses as we can. It's an imperative, and yet there's many barriers that exist to nursing education, to entry into the profession, and so this is lifelong passion of mine, and I'm doing what I can. I wonder what you're gonna do, right? Like after you have that license, and so that. I'll share something else with you, and this is very alarming. This is a very recent study. I think it came out last year at some point, and that shows that 50% of all new licensees leave their first employment, so they change employers within the first 2 years of being licensed, so they leave their first job. But what's more alarming is that a whole third never goes back into nursing as a profession. I don't know what they do, probably get a real estate license or something like that, but they say not for me. Why? Why do you think this happens?
Toxic work environment?
It is an unspoken thing, toxic work environments, short-staffed, it's a lot of pressure, and schools unfortunately do not prepare grads for reality of the practice. The practice is tough. I'm telling you now, it is tough. And until we address these like bigger systemic issues, and until we get more practitioners into the workplace and to the bedside, it is not going to be much better. What can you do though to prepare yourself to go and into an environment that may not be all that, welcoming and perhaps a little prickly or a lot? What can you do?
Gain a certification, like CNA certification, or work in a hospital environment to get some experience.
Yeah, that's actually a pretty good idea, right? So exposing yourself to the environment prior to, and not just in terms of a clinical rotation, right? Because you're not necessarily immersed into everything that may be happening while you're on a clinical rotation. So your view is somewhat rosy if just from that. If you get like an entry-level job and then in the environment and start adapting to that environment, building resiliency, right? I mean, like resiliency, unfortunately, is not a thing that that we have as a population anymore. We're like, oh no, I'm falling apart. It's like, oh no, she said this. It's like, pick yourself up. No matter what she said, does not diminish your thing, right? But understanding that and being able to fully control your emotions. There's recent studies that like conclusive, right? We throw like stuff at each other. I mean, words, items, burritos, whatever. I mean, and so we over time have lost the ability, and the screens have a lot to do with that, right? And sort of this separation from other human beings has a lot to do with our loss of the ability to control our own emotions, right? And to master those, right? We constantly say, well, if only everything else would be better, right? I'd certainly be better, and I'll feel better. But waiting for everything else to be better and everybody else to be better, you will be waiting for how long? Forever. So it is learning to control you, learning to show up in a situation, and that's resiliency. That's how you build resiliency. That you evaluate situations on their face value. You don't engage in something that may be, just like sucking you deeper and deeper and deeper into conflict, and you learn to problem solve, and you learn to manage situations. Communication skills are essential, and the only way to do to practice communication skills, you either have to be in an environment and then apply what you learn, or we give you another thing which is absolutely cool, and you do it in a immersive simulation and virtual simulation to where you communicate, and now it's AI driven. So whatever you say, it's going to listen to you and answer accordingly. And then, so you can practice and you can train, right? Like if I go this way, and you can go into those scenarios over and over and over again. And there's, different scenarios as well. And so you can say, okay, like after I passed, right, got my check in the DCBC or whatever, and let me go and try saying this and see how would that work in this situation. And the agent will respond, or whoever it is, family member in the corner, or the patient, they will respond accordingly to you. And then, so that's how you practice, but you have to sort of practice and practice and practice. Studies are conclusive that what new grads are from everywhere, I mean, it is not just nursing, it is absolutely entire higher education and professional education. New grads are missing the soft skills, right? Communication, de-escalation, problem solving, reasoning, critical reasoning. So pay attention to that. developing those is very important. We give you resources that are available to you for you to be able to develop that, but it is yours to learn, and it is yours to hone, and so forth. Any other ideas on why? I'll tell you. The entire system of nursing education is set up to count hours rather than focus on competency development. Please focus. We tell you exactly what those competencies are on the programmatic level, on the course level, on the lesson level, kind of unit level, whatever it's called, right? Focus on those. Make sure you understand what you're chasing. Not just blindly go and read something or engage something without having some goal behind it. You are building a competency that will serve you well when you get out into the workplace. And then you won't become part of these statistics, right? You will become part of changing the system in order to improve then the outcomes and health equity and all of this. Without you having it's futile, right? And so, lucky for you, you found Nightingale, because we actually are mindful about this and understand that this is what you must develop in order to be successful in your workplace and in the profession and in the kind of societal, from the societal viewpoint as well. Okay, so all of these things that I've listed, right, and we talked about already, should not be a surprise to you that, but let me ask you, how are we doing in US healthcare today? How are we doing? Not good, yeah, comparatively, right? Comparatively not good. If you start comparing us to, some nations in Western Africa, for example, right? Oh, we're winning. We're doing like real good. But that is not a fair comparison group. If we compare ourselves to the developed world, see everybody? Us. This is the relative performance effectiveness of our healthcare system. Everybody. And then the averages are up there. The top three, see, Australia, Netherlands, the United Kingdom. Top three average is the line like right up there. And then 9-country average, it's everybody but us. Over there, we certainly are winning. Just not in the right direction. This study has been published for the every few years by the Commonwealth Fund for the past 20 years. And our position has not changed. It has not improved. If anything, we are, again, on the wrong tracks, going in the wrong direction. And we scratch our heads and we're like, well, why isn't that working? We're like, what am I doing right? Well, we'll talk about that like today, right, of why this happens, and then in the same token, by the same token, what is it that you can do in order to change that? But yeah, so let's look at some other outcomes. This is our spending, so, that is relative to our gross domestic product. Gross domestic product is all of this stuff that we produce in our economy. All of the services, all of the products, all of the milk, all of the expensive eggs, whatnot. And so per capita, we're about 70,000 or so. But our spend is absolutely out of line with anybody else. And this is another way to look at it. And our growth in spending on healthcare has been steady over decades, and we grow healthcare by about 8% or so on average per year. Does our economy grow at 8% on average per year? Not at all. We would be like winning for real if we were growing at 8% our entire economy, but we're not. And there's many reasons for it. We'll dig into it in a couple of minutes. This is just the spend broken down on what we spend, mostly on inpatient and outpatient care, and then there's medical goods, pharmacies, so forth. Everybody else, as you can see, way less on per capita basis. This is the performance compared to spending, because you would think if you spend close to $5 trillion on something, you know how there's a bunch of like fights going on in like Congress about like 10 million there, 20 million there. Whoa, 5 trillion. You would think we would be the healthiest nation on earth, right? We'd be like, wow, look at us. Yeah, look at us. We face the most barriers in affordability and access. Equity. This is the access problem. So 50%, and you can't quite see the colors on this, but 50% of low-income populations in the United States report access to care problems, right? There's some problems exist. 27% of high-income population reports access problems. Yeah, we have a long way to go. Whereas Netherlands there, it's the low-income people at 27, right? So not great. Oh yeah, skipping care, medications, diagnostics, treatments because of cost. This is one bright spot that our care process, we're actually good. We're actually good. Our system is well set up to produce good outcomes, and yet it doesn't. So, yeah, this should not be a surprise. We have the lowest life expectancy at birth compared to the other developed world. Yeah, it's like everybody on the average and us, this dip, we figured why that was, right, for everybody, COVID. But yeah, it has improved, but comparatively, again, we're just not there. Avoidable deaths. Everybody over the past decade have reduced their avoidable deaths by quite a bit. We're still the highest, and we only reduced by 5%. The last decade. Winning, right? Yeah, only in the wrong competition. Yeah, so there's the accidents. You were right on the accidents. I mean, we lose a lot of people to those, right? And these are not just, so accidents are things like not just the cars there, but industrial accidents, gun related accidents and deaths are in there. So for intentional self-harm, big. That one is absolutely unacceptable. This is maternal death per live birth. So we rank at like 47th or whatever in the world in this. The richest nation on earth cannot figure out how to prevent maternal deaths. And many countries have. And reduce and reduce and reduce. Which population do you think suffers the most? Black women. They're twice, or maybe it's 3 times. I'll have to look it up. Don't quote me on that one. Jumble in the brain, but much higher than white women. Cultural things, and also the lack of that mirroring at the bedside, nurses, doctors, so on. So it is, so there's a lot to be desired, a lot to change, change that has to come. Love this one. 40%, 29% of the US population have more than one chronic condition, adults. More than one chronic condition. More than 40% have at least one. Wow, how are we doing with like prevention and, yeah, not that great. Health promotion, right? Not at all. Obesity. This is severe overweight. 40% of US adults. 40%. And increasingly so in the children and teenagers. Nevada is at about 42. So it's higher than the national average. Yeah, you guys have some work to do. The West Virginia is the highest at 50, and District of Columbia is the lowest at 33. But 33 is nothing to write home about. I mean, that's a third of the population still. So, and obesity, it's not, there's a lot of this sort of thought out there around, well, don't shame me. It's not about that, not at all. It is not about body images. What is it about? The what? Quality of life implications on your health. Studies are conclusive on heart disease and diabetes and like osteo conditions, and so on and so forth, as to the leading kidney disease, cancer. It doesn't necessarily connect to the weight, right? But there's other conditions that are much more directly correlated to this. And again, this is where multiple chronic conditions come from, a lot of them. And so managing that and getting the population to be healthier, whose job is it? Yeah, well, yeah, it's like, it's my job, right? You have to sort of, like the royal we doesn't work. Because as soon as you say, well, it's us, we are responsible, and then nobody does anything, right? Because it's like, it's just like, since it's we, as soon as you translate it into I am responsible, right? Likely responsible to figure this out for myself and move it forward, and then also manage it in the populations that I'm working with, right? So now, chronic conditions are expensive. When somebody gets to it, and the vast majority of them are what? On the other side. They're preventable. The vast majority of chronic conditions are not genetics. The vast majority is our lifestyles, is the lack of health education, and so on. And who's responsible for health education? That's very good. Yes, you are. Every single one of you, every single one of out there. But what do we do rather? It's like, well, I'm gonna work in, I'm gonna land me in that Grey's Anatomy hospital or whatever, right next to the McDreamy or whatever, or whatever floats your boat, right? And it's like, oh, it's gonna be so sexy, drip, 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 and ICU, and like just a couple of patients and all of this, and then I'm gonna clock in, clock out, and it's just a beautiful life. That is not going to change the outcomes, the systemic outcomes, right? Unless, if that's your job, that's fantastic, but it cannot end there, right? You have to become the agent of health and health promotion and prevention of diseases in your community. Whatever you consider your community to be, that is yours to do, right? Yours to educate folks. This is a better choice than that choice in this journey on a health continuum. So, yeah. To summarize, we rank the worst. And by the way, hopefully questions are going out there into the chat. Yay, Brianna's paying attention. $4.9 trillion in 2023 bought us all of that. Not great. We're not doing great. There's still the underinsured, uninsured problem, and so on. But yeah. Okay, well, how are we doing? Are you ready to do something about this? Yeah. Good, good. Like, you're not sure? She's like, oh, I'm not just saying this, I'm thinking it. Say it out loud. I am ready. Like, I'm going to do it, right? Because without you, this song and dance is not going anywhere. Like, and the only reason I'm doing it, and it's, you know, is to get you on that path of getting the population healthier and doing whatever it is in your power that you can do to do it. So, okay, let's talk about, this is just sort of the setup of our finance system. This is who pays. Now, so Medicare, that's federal government. Medicaid, that's a combination of federal and state government. Private insurance pays a lot, but you know, not as much as the government. And then you see the out-of-pocket costs and so forth. Now, where does the money come from? The federal government and state government money come from? Us. Yeah. Exactly. Okay. So taxpayers pay already for the vast majority of it. Out of pocket, premiums, you know, I mean, the companies do contribute, and we'll get to that. But this is what it looks like. So household out of pocket, but total spend is much higher. But the vast majority of that other spend, it still comes out of taxpayer pockets. Everybody with me? So there's no like magic something that, you know, somehow you're avoiding paying for it. We're all paying for it. This is the sponsorship back to that. So private business, so businesses pay about 18%, other private foundations, so forth. So about a quarter comes from, you know, money from outside of the taxpayers' pockets, and then the rest, the 75%, comes from there. What is the difference between our system, the way our financial system in healthcare is set up, and all those other countries on the list that you saw that get better outcomes than us and spend less? What is the difference?
The government controls it?
Not necessarily. Not in some of those countries, yes, it's fully owned. So government, like in the UK, the government owns both the insurance side of things and the you know, most of the provider side of things. That's not true for all of those countries. What is the one uniting factor, though? What do those countries have that we don't? No, they don't have necessarily free health care. Well, free health care comes from taxpayer payments, right? Like, you still pay for it. I mean, it's just in a different way. But what is the difference between Canada, the UK, Australia, Netherlands, Switzerland? What's true in those countries? Universal health care. What does that mean? Yeah, everybody gets access and everybody pays into it. That's simple. But there's only one payor. It may be a governmental payor. It may be as a private payor that's set up to do that, but there's one. And the universally everybody gets it. So everybody pays. We in this country made it into a big political hoopla that essentially says, well, no, we don't want to spend, like, why would I pay anymore? And like, well, I'm healthy, I'm young and healthy. And like, well, screw you old people. I was like, who cares? Why should you care?
You're gonna get old one day.
Yeah, because if you're lucky, you'll get old. And then imagine the new generations kind of like, I don't care. Yeah, this is sort of our attitudes toward each other. I don't care what happens to you, as long as I'm okay. But guess what? Every single one of us will need access to something at some point. And wouldn't it be good to have it, to have that access? And it has been proven by data that all of those systems get better outcomes and spend less than we do collectively. It's like, wow, screens are like, ooh. Is this a political argument? It's not. It shouldn't be. It's a health argument. We pay for it. We already pay for it. Taking anything away, Medicaid, whatever it may be, is just going to exacerbate the access problem, the outcomes problem, and so forth. Now, do some people exploit the systems? Absolutely. Yeah. You know, but you cannot design the entire system to manage just that, the exploitation of it, right? So redesign is necessary in how it works here, but sort of like completely, you know, yanking everything out is not the way to do it. There is a way to do it. There is a better, like where our systems are inefficient, they're ineffective. I mean, we spend a lot where we shouldn't, but it can be done in a different way. Okay, and here's where the dollars go. Hospital care, $1.5 trillion, so 30%, about 30% of the entire spend. What do you think? What do we treat in hospitals nowadays? Emergencies, yeah, you know, accidents, right? Like we treat that there, but that's not the bulk of it. What do we treat mostly in hospitals? It is in-house patient care, but what kind of patients are they? End of life? Not the bulk of it, not end of life. Not necessarily, no. I mean, we treat, okay, I'll give it to you. In acute, oh, no, let me ask it this way. Okay, like, go back to like 1950s, and I know that's like, whoa, ancient history, but, you know, 60s, whatever. What did we treat in the hospitals then? Like 1950s. The entire system was set up for like one particular problem in the 1950s. What was the biggest problem we had in the 1950s? No. Babies. Oh. Babies was our biggest problem. The baby boom. The baby boom, yes. You know, all the men left for a while, and, you know, everybody was like, pent up, you know, energy, and hormones, and then, like, everybody gets back, and it's like, let's make babies! And then it's like, you know, you get a baby, you get another baby, and then the system that we had prior to that, sort of more kind of community-based, midwife type of thing, it wasn't scaling fast enough in order to be able to take care of that many babies being born. And so a lot of these initial, like big, you know, care facilities, acute care facilities, episodic care, right? Because, you know, you have a baby and you mostly get out like fast, have been set up to do that. And much more accidents back then, right? We didn't have OSHA or anything like that. So people are like, well, oops. From a pole. And so we're treating accidents and things like that. We didn't have prevalence of cancer back then the way it's now because, you know, smoking was sexy. and well advertised. Some kids still think that, hopefully none of you, it's like, oh, now I'm not smoking now, I'm inhaling. And it's like Game of Thrones. And it's peach. And it's like, of course, it's like, nah, yummy. Not a good idea. Not a good idea. So anyway, what is the difference now? So the system was set up for truly episodic acute care, emergencies, accidents, babies, so forth. What ends up there now in this system? Untreated and exacerbated chronic conditions. Poorly managed chronic conditions is what we deal with in hospitals, and it's very, very expensive. So, because again, the effective management of chronic diseases is not existent, because everybody wants to, right? Like, and hopefully some of you will be like, I will work in a community setting. I will work in a public health setting. I will work in a long-term setting where the prevalence of chronic conditions is through the roof. And if you do your job really, really well there, those people will never end up in acute care, ever. They will not need to go to the hospital because we as nurses that taken care of them have done our job appropriately. And so pay attention as you go through the program. Pay attention to effective care and effective management of people and their health, promoting health, right? Health education, preventing disease, back to that health education, and effectively managing chronic conditions because they are costing us a lot. And after something ends up in acute care, it is very difficult, and becomes very expensive, and it's very difficult to treat at that time. Whereas a couple of months prior, it would have been very cost effective and very fast and very outcome forward. So yeah, retail drugs, we'll talk about that later. By the way, like we're one of the very, very few countries where advertising pharmaceuticals on TV is, accepted. We finally stopped advertising cigarettes at some point, it's like the cowboy and a camel, it's like didn't become, that was banned. So you're like, oh, sexy, woo, Marlboro, Lasso, and I remember the days. It was fun. I smoked too. Yeah, I mean like sexy cowboys, what? So that's the spend. And this one, before the break, we'll end with this. Waste in the system. Waste. And so these are, it's estimated that as much as 25% of the entire spend. So if you apply 25% higher end estimate to the 2023 4.9 trillion, that is a lot. That is way over $1 trillion. 1.25 trillion. Do you know what a trillion is? At some point, do an exercise, right? Because everybody's like, okay, if I'm making $100,000 a year, right? And it's a 1 and then 5 zeros after it, yeah? Like, amazing, would be amazing. My life would be so awesome. Yeah, so whatever, that, you have that. And then it's add another zero. You're like, wow, if I had $1 million by the time I retire, I probably will do pretty well, right? I can travel and see all national parks and whatnot and whatever it is that I want to do. So that's 1 0. And then you add 3 zeros to that, right? So it's 1,000 million. What do we call that? That's $1 billion, right? And it's like, whoa, that's a lot of money. I don't even understand how much money that is. And it's like, well, that's a lot. And then you add 3 more zeros on top of that. That's $1 trillion. Write it out and see how many Seeing those zeros on paper in front of you, like looking at it with your eyes, it is alarming how many zeros are there. And then you multiply that figure by 5, or in case of a waste, 1.25, and you go, wow, should I do something about it? Yeah, I think you should. There's something everybody can do in order to. So, failure of care delivery. This is where providers don't communicate with each other. Everything is fragmented. All the medical records, one likes that system, the other one that, likes that system for documentation. Nothing is gelling and connecting. We waste a lot. Care coordination as well. So I've actually talked about the care coordination. Care delivery is when somebody is in the process of receiving care and something fails, and it fails a lot. So care, for example, in nursing, medication errors are prevalent and very expensive, and we waste a lot of time. We over treat, do things. Over treatment is right there, low value, because why is over treatment there? Why are we over treating? Because we're short. We're short of providers, we're short on time, right? It's easier to prescribe something and get you out of there, because you're like, I want to feel better. I want to twirl in the hills just like she does in that one commercial. Ask my doctor about this. I'm asking you. And your doctor has exactly 30 seconds with you, and they're like, okay, get out of my hair. Here you go. Go do it. And they're like, yeah, and especially if you have insurance, right? And like a $10 copay. Good. Gimme. And so fast fix, I want it now, rather than shortage of providers, no time to really spend with somebody and to figure something out of whether or not they're needed or not. And so it's constant. Pricing failure, $250 billion on pricing failure. You know how on Amazon, like all of you shopping for something, and then something's like 2 cents less from this, there's like other options, and you're like, oh yeah, no, that one. I can wait a couple of days, I don't need it right now, but 2 cents better, yeah. So we're like so price sensitive, conscious, shopping online and doing all those things, and we completely don't know how to shop for healthcare. And newsflash, the same procedure, and I always give this. Some years ago, I had trouble with my shoulder, and I needed an MRI with contrast on my shoulder. And I shopped around, and the prices I was quoted, everything from $575 to over $5,000 for the same thing. Guess what I picked? $575. Like, good. Yes. If you don't, and we don't as consumers, we are not educated as consumers to price shop. More expensive doesn't mean better quality. More expensive doesn't mean better outcome. It has been proven over and over and over again. And yet us as consumers, we're just not educated on whatever, and it ends up in fraud and abuse. There's quite a bit. We talked about that. And then the administrative complexity, $300 billion. $300 billion is because we don't have a universal system. And every single provider has to essentially negotiate and establish systems and pass-throughs for payments and so on with every single insurance company. And it is a nightmare, and it costs a lot. And there's a lot of inefficiency and failure in that particular system. So, yeah. Winning indeed. Yeah? Okay, so we'll see if there are any questions or comments or anything like that. Everything
The chat's going really fast, so there is a lot of stuff going on, but no.
Okay, all right. The chat is going fast. I like it. You know, people are engaging. That's fantastic. Okay, so let's take. We're gonna take 13 minutes. How about that? Stretch your legs, get some food, whatever it is you do there, and then we'll come back at 25 after the hour, wherever you may be. Oh no, I won't be at that meet and greet, but there's All good? Everybody good? Okay, a sip of water. Then we can get back on it. All right. Okay. How are we doing back here? Good? Okay. Well, welcome back. Yay. Let's jump back into it. I'm going to pause and see whether you have any questions on anything that we've talked about so far. Comments? Any sounds at all? You guys? Yes, Brian. Okay.
There's a question in the chat. It says, how do differences in regulatory agencies and approval processes affect the availability of experimental or extreme medical interventions internationally, and why do U.S. citizens travel overseas to access these treatments not approved by FDA?
Wow, that's part of it. So really again, so like the medical travel, it's some things may be more affordable elsewhere, and so that's why people choose to go. Obviously that, quality or outcome or whatever it may be is sort of like taking at your own risk type of thing. But I think affordability has a lot to do with it. Again, the care process itself, we're rate pretty well. Right? If you have access, I mean, chances are, and again, it's and a facility is staffed well, and all of those good things that you need, the outcome will be good. But that's not always the issue. And what was the first part of that question? Something regulatory systems.
How do differences in regulatory agencies and approval processes affect the availability?
So I'm not sure around like how regulation outside of the U.S. really works. So that answer is I don't know. For here, I can give you one example of the sort of upstream regulatory. I'll give you two. Upstream regulatory structure that exists in the vast majority of the United States. Utah is the only exception. That essentially is concerned with two things. Clocking in hours for nursing education, right? So they tell you, the regulation says you need 100 hours of this and 50 hours of that and 20 hours of that and whatever. There's absolutely no evidence that exists to support any of those figures because adult learning is not about counting hours. For somebody, something may take 20 hours to get to the same level of competency. Remember equity thing, right? Yeah. And for somebody else, it may take 40. So to get to the same level of competency and the same level of outcome. So saying that everybody needs 40 or 20 is absolutely preposterous. And yet our entire regulatory system is set up on that, right? Because it's easy. It is easy to count hours. It is not easy to measure competency, right? And determine whether somebody is competent or not. So the entire premise of that, like X number of hours will get you to be a nurse or an effective nurse or anything like that it's a myth. It's not supported by evidence. And yet again, 49 states have some sort of type of a thing like that, requirements like that in their regulatory process. Another thing that exists in the vast majority of states is that the quality measure that they think what is quality is whether or not a graduate of a program can pass the licensing exam on the first attempt, right? And if they, so many percent, right, and that varies from state to state to state, pass on the first attempt, it's a good program. And when if they don't, then it's a bad program. Again, not supported by evidence. It is absolutely a made-up thing. It is not an indicator of quality. Like passing a standardized test on the first attempt is not the goal. Should not be the goal of education. developing competencies should be the goal of education. And then because all of us are different in how we approach test taking, and the literature is conclusive on this, is that white population performs better on standardized tests across the entire spectrum, across secondary education and higher ed and all of this, than anybody else. And so, because of the cultural differences and sort of the anxiety that may be created by like many different reasons, but the literature is conclusive, and we will be publishing the first paper of its kind on NCLEX, proving the same. Like the data proves the same thing, and that's why you don't have as much mirroring, cultural demographic mirroring in the profession, is because we're focusing on the wrong thing in policy, right? And whatever you're focused on, so we pay for hours, right? We pay schools to count hours rather than develop competencies, and then we pay them for their grads to pass on the first attempt. Well, many, like community colleges, more non-selective schools, they do not graduate but 20-30% of their classes, because they think that no, we cannot graduate people whom we don't think going to pass on the first attempt. These people may be fantastic nurses, resilient, all of this, just not great at standardized test taking. Eventually they will pass, but maybe not on the first attempt. As a matter of fact, our data is conclusive that within 2 attempts, like high 80% of all grads pass. And with persistent attempts, everybody passes. If you persist, if you're resilient, if you keep going at it, you'll pass. And yet again, so the system that we created both creates the shortage. We dump a lot of money into nursing education system, and producing one nursing credential at a community college costs hundreds of thousands of dollars. Hundreds of thousands, one. And we're like, oh, why aren't we doing that good? Look upward, look at the regulatory system, look at the finance systems, and they will tell you this is why I'm a lot. You remember I have a business degree, right? And so I'm a lot about numbers and evidence and finance and digging into that to try explaining why the outcomes downstream are not great. So I don't know if that answers it, but it's sort of like regulatory systems have a lot to do, and financial systems have a lot to do with the outcomes downstream in everything. And every outcome that we experience, whether it's the shortage, whether it's whatever it may be, is by design, it's not by accident. Systems are designed. One of my most favorite quotes of all, Dr. Deming, back in the 1950s said, every system is perfectly designed to produce exactly the outcome that it is producing. Perfectly designed to produce exactly that outcome. So, being surprised about the outcome, we shouldn't be surprised. And then any kind of thing that we do very close to the delivery of care, for example, and the outcome is not going to change the system that will produce it better, right? You have to start looking upstream. You have to start figuring out what do we have to do upstream. So effective management of chronic conditions will result in cheaper healthcare downstream, so less spend, and better health, better outcomes. That thing alone, if we manage chronic conditions effectively. And yet, in nursing schools, outside of this one, nobody learns about that. That's where the answers to our biggest problems lie, in effective management of chronic conditions, considering the US population, and you saw the numbers. 29% multiple, 40% at least one in all adults. That's a lot to manage, and has to be. So anything else, any other sort of questions before we continue jumping or moving forward into it? All right, okay, so we'll talk about this. Let's talk about these. So I have a cheat sheet here for some of these, but why do you think, so let's take climate. Is it a health problem, climate change? Why? Why do you think it is? Like, it conclusively is. Why do you think that is? Why is it on this list? Why climate change affects health? Well, you know, exposure to sun, yeah, you can prevent that, right? But what else? Speak up, I can't hear you. You know, air quality is a part of the climate. It does affect, yes, the prevalence of you know, upper respiratory asthmatic conditions and things like that. For example, on the Wasatch Front, where I live in Utah, is the highest because, you know, our air is very polluted, and some parts of the year we rival Beijing really in our air pollution because of how atmospheric pressure works and keeps all of the exhaust down to the valley, to the valley floor, and so our prevalence of childhood asthma is the highest in the country. So yeah, that does affect, right? The heat itself affects health, right? Every year you hear Texas here in Nevada, and like people, you know, heat strokes, passing out, and like health issues. Yes. What else? Contaminants, right, from production or things like that would be affecting it, right? So it is these issues are and the warming, you know, this climate change and warming of the planet, and imagine when some areas become unlivable because you cannot grow anything in those areas agriculturally. Now, access to what's agriculture? Food. Do you think lack of food somewhere would result in health issues? Yeah. Can't go like very far without eating, you know? Like that, you know, those of you who do your, what is it called? Yeah, fast for like, you know, the religious purposes or whatever. I mean, a day it's like, oh my, wow, I'm hungry. Yeah, but then what that does, the displacement of the population, right? Then because people have to go somewhere else, move somewhere else in order to be able to access food, to access water, and all of this, right? And then that gets, so there's issues galore around this, and yet we, you know, like, nah, not my problem. Yeah, all of our problem, no matter what whoever says on TV. It's not a political problem, it's a health issue. I am only interested in health and promoting it and driving it forward and improving health outcomes, and that affects it. Gun violence, why is that there? Is that a health issue? Yeah. If you're not dead, you know, which is like the ultimate result of the health failure, then you end up in very expensive care, right? What you don't hear on TV constantly, because there's only certain things that you hear on TV about guns and gun violence. The prevalence of death by suicide or injury by self-inflicted injury by guns way exceeds that of guns, you know, just gun violence that inflicted on somebody else. Much higher. You don't hear about that, right? So is that a health issue? It's a health issue. And getting, and the availability, right? So, and I would like, again, I want everybody to be so clear that I'm not making any political statements or arguments here. None at all. But when somebody is depressed, really, really depressed, and they can walk into a store and they decided to end their life, and they can walk in the store and buy a gun immediately without any wait, they can walk out and kill themselves, and that's what happens over and over and over again. So one, our systems are not set up to deal with emotional wellness, to deal with mental illness and all of this, and yet then and that all implement is readily available to everybody. So it's like, and you may say, well, that's their choice. Would they have made that choice if perhaps some, counseling was available before? Or before a gun is sold, you had to go to mandatory counseling. You had to talk to somebody that can talk you off the ledge and figure out why you're buying that gun. Yeah. So is gun policy a health issue? Yes. Nurses should be interested in that, and I think so, if we're interested in saving people's lives. So it's not about I'm all for the Second Amendment. But again, how the system is set up, that's the question, right? So social isolation, loneliness. Wow, there's a lot of data on this. I'm gonna read you some facts. So let me find it. Living in isolation, and this is like studies over the past decade. Living in isolation reduces our chances of survival, and social isolation increases the risk of premature mortality by 29%. What are the most socially isolated groups in the United States? Who? The elderly, that's like one group, and teenagers, kids, because they're here. So issues on both ends, right? Poor social relationships, social isolation, and loneliness can increase your risk of heart disease by 29% and stroke by 32%. Smaller social network is associated with an increased, and social not in terms of like your hundreds of friends on Facebook. That is like fake friends, like not it. Having this, right? And like now you guys met each other and like, yeah, be my best bud. Smaller social network size is associated with an increased risk of type 2 diabetes and of other diabetic complications, including heart attacks and kidney disease. Among older adults, chronic loneliness and social isolation can increase the risk of developing dementia by approximately 50%. Is social isolation a health issue? It is 50% more chance of developing dementia, which is difficult. I mean, it's like treating that and taking care of dementia is very expensive and it's heartbreaking for families and providers and all of that, right? And yet we can do stuff to improve that, but it has to be done on the community levels. And who's going to do it?
I am.
Yeah, very good. That's right. Good. Some of you are like getting the gist here. That without you getting involved in some of this, it's like, well, Mikhail, but how can I change public policy really? Like, what? I'm just I'm just me. I'm just alone. I'm little. How am I going to do it? How are you going to do it? Change public policy. Some of you, I hope, will run for local offices when it's time, run for state offices, and run for federal offices, right? Because that's where, by the way, there are three nurses in Congress. 3. 0 senators, 3 Congress people on the House side. 3. Do you think that represents the 4-some million of nurses that are there? Nope. Because why? Well, like why? Because we've been taught over and over and over for decades that our responsibility ends when we clock out and get out there and then go and shop for shoes or whatnot, right? It doesn't. And in order to drive any meaningful change into these systems and change these regulatory things that I told you a few about nursing education, policy must be changed. But you have to, I mean, like, you can influence it, you can advocate much more, obviously, band together with others to advocate for change in something. And nurses, when banded together and advocating for change, can be very powerful. It's just we gotta dial it in and agree that, like, our responsibility as a profession to drive these changes. And on the other side, being more socially connected can improve stress responses, minimize negative health effects of stress. Social isolation or even perception of isolation can increase inflammation in the body to the same degree as physical inactivity. Same degree. You can be active and socially isolated, still will be inflamed. Yaha. So that's, yes. Let me give you the gun. Firearms play a central role. They're the leading cause of death among youths aged 1 to 19 and accounted for nearly half of increase, this is 2020, of all-cause mortality that year. 1 through 19. Yeah. So as you start, as you start digging into all of these data, it becomes clear that we're not doing well, right? And those big outcomes, kind of like the system outcomes that I was showing you before, they're not by accident. They're like it's the design of everything around us in our lives that leads to that. And if we want something different, we need to drive these changes forward. Behavior and lifestyles. That one is poor nutrition, yeah. Everything that's delicious and easily accessible, it's like so yummy. Yeah, I do an experiment. Take like a chunk of lard, yeah, like put some sugar in it and some salt, mix it all together, put it in your tongue, it's gonna be like, oh my God, that's so good. Yeah, we respond to that. We're biologically programmed to respond to fat and sugar and salt. It's like, over, eons of evolution and development of human beings, like our taste buds are programmed to do that. Because back in the day, finding something that was fat and sweet and delicious, that was a rare occasion. And so we're like, again, we're evolved to crave it and to like pursue it, but it's available everywhere. And we're like, no, forget apple. Nah, disgusting. No. There's no, there's some sweetness in apple, so it's something, but like very little fat. None. And so we're not, ice cream. All of it is there. Fat, sugar, and a little salt. Delicious. Yeah. So poor nutrition, lack of nutrition education, lack of exercise. What is like, I forget what it's called, like when people now go into like, the endless scroll. The scroll never ends, everybody knows, right? Like there's no bottom to it. Yeah, you can never reach it. And so people like, yeah. So instead of moving or doing anything, it's like, ooh, yeah. It's like, oh. It's like, ooh, I like that, whatever it is. Like belly dancing. Whatever your algorithm feeds you. And preventable and poorly managed chronic conditions, we talked about it quite a bit. Inadequate health promotion, again, nursing schools don't teach it. Don't call on their grads to say, hey, it is you. It's your responsibility. We are the largest healthcare profession in the United States, the largest. We're short, but we're still the largest. And yet none of us take responsibility to, or very few of us take responsibility to drive any sort of meaningful change into our communities. I'm not asking you to do like everything for everybody all at once, right? The everything bagel. No. Like do what you can in your community. What can you do now? That's the question. Tell me, what can you do now? Educate others. In order to do that, what do you need to do for you? Educate myself, right? Exactly. You have to learn. This sort of, notion that, well, I'm just going to eke by and get that C because that's a passing or whatever. I don't know. Like in different courses, I think it's different things. I don't know exactly like what the passing grade is, but that C is not enough for you to be effective, or for you to know your stuff in order to be able to show up anywhere and be effective. Chase competency, chase effectiveness, rather than, a minimum grade. And sometimes, it's tough, and sometimes you have to rearrange your whole life in order to be able to devote more time, whatever. Some of you got to say bye-bye to Facebook. I mean, and endless scroll and Insta and all of that stuff, right? That like constantly sucks you in. It's designed to suck you in and keep you there. So get out, break free. Go study instead. Learn something. Connect the dots. Develop reasoning. All of this. Because then you will show up in your community, wherever it is, and you will be effective. And that's what's needed, right? So in order to educate others, you have to know your stuff. Absolutely must. It's not going to happen otherwise, and it's not going to happen miraculously. I wish I was Oprah, and I'd be like, oh, you get it all in your brain, and you get it, like, everybody gets it. It's like, direct transfer of, like, everything. It's like, here you go. You're welcome. That would be nice. Impossible, right? So you guys, you have to make it your mission to become competent, right? And competent, and then in a package of all of the soft skills, resilient and a good communicator and a good de-escalator and problem solver, right? So in order to address all this, we already talked about reactive system that we've built, right? I mean, the system was built to be reactive to the babies, to the 9 months kind of complication that happens, to folks. And then we continue driving the system forward and propping it up and dumping a lot of money into it without really pausing and understanding that only proactive solutions in health will solve the systemic outcomes, will get us closer to equity and all of that. And by the way, access, right? Think of it this way, and I'm absolutely serious about it. Access to you for 99 people in your community that are not nurses and not doctors or whatever should not be that difficult, right? As a this is how it used to be back, like when we were closer as communities and neighborhoods and all of that. Everybody knew who the nurse was, right? And could go and say, hey, or you could notice something, somebody shopping in the store and say, hey, knowing what I know, that's not the greatest choice. Try some edamame. Yeah? All right. So, I mean, all of that, access equity, we've discussed that. Financial system, right? So employers pay a lot. You saw that, right? The private business pays a lot into the system, and most of them completely disengaged from driving any sort of outcome or any kind of change into the system itself. So, when you are, get to work, you don't have to be in management to become a leader, right? And to propose things and whatever, and to manage and say, hey, how about, I'll give you one example. This is what we do at Nightingale for our collaborators, so for our staff and faculty. We have a program that allows them to, through doing certain activities, sleeping better, eating better, moving more, and all of this, earn buku premiums, premium reductions on their healthcare. And for, so a collaborator, him or herself or themselves, can get to, on their individual premium, to 0. cost them nothing, right? Family, we're ready, but we're sort of, getting that. That drives health into our collaborator population. Better wellness. And people do. People are there. People show up and, and collaborate with each other and connect with each other. I love it because, there's something, their financial wellness is better because they don't have to. Like, all it takes is, getting out of bed, 20 minutes earlier and going for a bit of a walk or a run or whatever, or screaming like me, screaming at the thing. The trainers on Apple Plus. But this is very rare, essentially, compared to all of the entire business and employment sector. I mean, it's rare that happens, right? I mean, some like healthcare employers, when they can, they're like, oh, just here you go, free to you. They still pay, and then they ask for nothing, they're completely disengaged from any outcome. So when payers are completely disengaged from outcomes, outcome is not going to become any better. So that those systems making those connections and building that, you'll have the power to do that, create that. It's a simple thing. I'll give you another one. This is years ago. This is where I first learned about it. Safeway. They're a big food store corporation thing. They have several brands. And in their corporate offices, and this goes back, I don't know, before 2010, they figured it out. They're like, okay, so in our cafeteria, it's the burger and fries priced at $4, and then the grilled chicken salad priced at $8, and people go for the burgers constantly. And they're finally, oh, maybe not the best thing to feed our people. And so rather than taking away the choice, they say, okay, and kind of direct whatever, we're just going to swap the price. We're going to put $8 on the burger and $4 on the grilled chicken salad. Guess what? Everybody started eating grilled chicken salad for lunch. And then they measured the outcomes over time, and it was effective. Their health and wellness improved of their employee population. That is easy. So they, perhaps lost a little bit, just a tiny bit of money on that dish, perhaps, right? But then the gain that they got in employee health was tremendous. Very simple things that then lead to big changes. But you change something upstream, something here, flip the price, then the behavior changes, and then the choices change, and then you get to a better health outcome. I have another example. Kaiser Permanente. Somewhere in Southern California, in a predominantly Hispanic community, they partnered with a school, just a local school where kids were primarily Hispanic kids, and they introduced to the kids, because they're like, how do we drive this into the population? The edamame. And really started giving them, and edamame is amazing. It's nutritious. It is really, really good food. It's full of protein. I mean, it's what our bodies need. And yet, in that population, who knows about edamame? What the? And then the kids would go back home and be like, hi, mom, edamame. And they were like, what? It's and cheap. So kids started requesting edamame at home, and then those the parents are like, okay, and then everybody figured, okay, this is cheap and it tastes good, and you can do different things with it, put it in rice and do whatever, and kind of, so cheap but good nutrition. And so they changed that particular community's behavior as it comes to buying habits and eating habits and all of this, and then which results in better outcomes and preventative things, right? Prevention of disease, which then is cheaper for whom? Kaiser Permanente, who covers them. Yeah, see how the whole thing works. So there's many things. Connects the dots, and our costs and provider shortages obviously contribute to this. And so anything else on this? Factors that affect our poor health outcomes. Anything else you guys like can think about or add, or anything else there in the cyberspace before we jump into high spending more? No? Okay, all right. So now, by the way, we're going to finish with this. We're going to go through the next one, which is the factors affecting high spending. And I'm giving you some examples of things of what, like people can do and nurses can do. And so then we're going to have a bit of a discussion as to like, what are you going to do actually? And what are you committing to, right? Because you have to commit to something. Again, waiting for some magic to change anything, right? You can truly wish, like cross your fingers and wish upon a star. You can pray, you can do whatever you want. It ain't gonna change a thing until you actually do something about it. Like other people won't do it, whatever. So like as we walk through it, I'd like one thing from everybody. Like this is what I'm committing to doing. And it can be big, small, whatever, right? It's like, I am going to run for Senate. Fantastic, awesome. I'll see you there at some point. Factors affecting high spending. Pay per service versus performance. You know how I use the hours example in nursing education, that schools get paid for the hours that they count, not for anything else, really? It's like, you did the hours. It's like prison sentences, right? It's like you count the hours, and it's like, here you go, we pay you per hour. Fine. Rather than any kind of performance. Same with healthcare. The value is in what? If we're to truly create value-based system that produces value for the amounts that are invested into the system, we have to focus on performance. We have to focus on the outcomes, true outcomes. And again, in education, competencies, right? Assessing those, understanding where you guys are, and like helping you get to that. In healthcare, same thing. Outcomes is what's important. Continually paying for service will never change anything. When payments switch, and as a matter of fact, this thing that's, dubbed Obamacare, the Affordable Care Act, back from in the day, one of the centerpieces of it that nobody knows about was to do just that, to direct Medicare money to better outcomes. Not just blindly paying for services, but to create accountable care organizations. So providers banding together in a community to care for that population and produce better outcome and prevent something, right? And make it more effective, make it cheaper, all of that. And it works. It works when that's done. But there's so little of it as compared to the big system. So you will hear this term value-based care. Value-based care, it's all about getting your dollars that you're putting into it to be much more effective than what we have. And hence you have to focus on the outcome, right? On the shorter term outcome and the longer term outcome for that population. Overprescribing, we talked about that, right? And it's like, so like, no, I want the antibiotic. But you didn't need the antibiotic. But I want it. It's a cold. No. Okay, go away. Here, go take it. And then continue contributing to these, strains of antibiotic resistant bacteria strains that are like not treatable by antibiotics, is because of overprescribing of those things constantly, right? And those germs know how to adapt over time. So unnecessary diagnostics, because care coordination is not there. It's like, oh, and then it's like my mom, she's like, hurts and hurts and hurts, and she goes to her primary, and her primary says, you got to lose some weight. So for the back to be a little, because there's a lot, and she's like, so comes back home and tells me, can you believe her? Can you believe her? She should look at herself. I'm like, okay, be it as it may, we're not discussing her, Mom. She's absolutely right. But that's not the answer she wants, so she goes to another provider. They're like, and they're like, okay, I'm like, oh, here's a pill. You know, and I keep like, physical therapy. It's like, hurts. I'm like, yeah, it's gonna hurt. You know, walking's like, but you know, over time, if you do it constantly, guess what? It's gonna be better. Yeah, no pain, no gain. But you know, we want easy solutions. We want immediate solutions, and those are not the real solutions. Are not immediate. They take time for the outcome to get there. But not doing anything, right, you never get to the outcome. So lack of care coordination, we talked about, yeah, litigious society, you know, give it to me or else I'm gonna sue you for my poor health and my, you know, choices. You're responsible. I mean, that's administrative costs, we talked about that, numerous providers, coordinating. That next one is, you know, please, in whatever it is you do in your practice, whenever you do it, and you can start now. You can start now doing in your communities, in your family, with you. You know, so you gain some confidence in it and some expertise in it when you apply it to you and your family. And then immediate, you know, circle of friends and you know, extended family. The health promotion, prevention of diseases, and effective chronic conditions management. And chronic conditions is where, like, most of the solutions lie there. If we've figured out how to manage them effectively and how to, like, help people navigate through it, it's like, it will change a lot on access and you know, it will reduce demand on acute, of course, reduce cost. Provider clinical shortages. What's your job here? Become competent, right? Gain all the necessary resiliency, soft skills, problem solving, all of this, yeah? Get licensed, and stay in the profession. And it's gonna be tough. You gotta set your mind to it now. Because if you ain't doing it, then again, we'll never solve it. And then you know, that's too in consumer education, or behavior. Oh yeah, our optimism. I love our optimism. I was like, you know, this is like a national treasure, our optimism, right? Like, we make it sad for a little bit, but then like we're, you know, staying very optimistic. And you know, those scary pictures on the cigarette packs with like trachs and stuff and whatever, and like, and advertisements on TV, there's like, don't do this. It's like, nah, I'm luckier than that. That's not gonna happen to me. I mean, here, oh, word, come through, like, you know, the casino hotel that I'm staying at. Woo! It's like that floor is a something with, you know, and everybody's like, it's like, oh yeah, that scary stuff is not gonna happen to me. Yeah, it will. Totally will. Just because, you know, we're a bit delusional doesn't mean it's not going to happen, because it's going to happen when you do it long enough. And yet again, there's no system, right? Like, there's no like, and like, come in here for counseling first, and then go out there, right? It all makes money, and all of it, and why not? And you know, it's like, oh, we got to support tobacco farmers. I get it, but at what expense to the society? And so that, again, not political, just health. Yeah, we've kind of gotten through all of it, all of the everything that ails us, and so yeah. Now we're going to talk about how you're going to fix it. Now, I told you my thing. This is the gig, and I'm doing it, and just continuing to do it. And then what are you going to do? What are you going to do? What are you going to do? Now, by the way, my email is there. Listen to me very, very carefully. I cannot change your grade. I have no power over your placement. I do not interfere in faculty matters. So don't use it, because people is like, oh, I'm gonna copy Mikhail and something is gonna change, on my demand for X. It's not going to change. The decisions that are made by faculty, by staff, are in alignment with the policies that are published, like that big book that none of you read really, cover to cover, but you'll sign for it. Yeah, catalog. Yeah, it's like, sure. I will follow all the policies and all of the, I get it, I understand, this is not guaranteed and that's whatever. And then inevitably it's like, no, but but I want it. That is nice. I cannot help in fulfilling your wishes. However, if you want to get in touch, and you can find me on LinkedIn, you can connect on LinkedIn. If you want to get in touch because you have a question about, you may have an idea about how to drive something, how to change something in your community, right? Or your employer, reach out and we can chat. Send me an email, again, connect on LinkedIn and message me, and then we can, I can help you think through it. I can, help you, perhaps point you to some resources that you may not know about. So use it wisely to change healthcare system and to bring health equity about and to improve outcomes and reduce spending and all of this. That's my jam. I would love that. Yeah. And don't copy me, on your registrar emails or whatever, because again, I was just gonna be like, oh, that's nice, and delete. Because I know we have people who do stuff in those departments, and I may know nothing about it. Yeah, I'm only the CEO. So, okay. So with that, let's talk about anything in cyberspace about how they're gonna, I'm gonna throw it to how they're gonna change or do one thing. I'm just looking for one thing that you're committing to do differently or to change or to whatever, or to do something. So what it is that are you going to do based on everything that was discussed today in order to drive this forward, our collective mission of elevating health? Okay, who wants to start? Come on. Okay, go ahead.
I'm currently CNA.
Okay, fantastic.
And during huddles in the beginning, I know sometimes it kind of gets hectic and a lot of nurses, there's situations, there's somebody
Pointed out these toxic work environments, and there was something that you mentioned about exercising and how that can also reduce stress.
Yes.
So in huddle, we can all start doing arm circles and jumping jacks or something that's small. That can help also.
Exactly. Get heart pumping, what happens? Endorphins are released. Yeah, as soon as you exercise, as soon as you start moving, it's it takes a couple of minutes. And you're like, ooh, this feels good. There's something about it, I can get addicted to that. Yeah, it's good. That's the good kind of addiction. But endorphins that you get from this, the doom scroll, yeah, not good, because it's addictive as well, right? So get addicted to the right thing, like physical exercise. That's fantastic. And activity, and then yes, and maybe it will elevate the mood of everybody, and then you yeah. Oh, very good, simple, good, okay. All right, what else? Who else? Who's next? You were next, yeah? Right? You raise your hand. No, yeah.
Almost on the same lines, just being more conscious and more proactive on my own health and stuff like that.
Okay, so
offset my chronic conditions that are just around the corner.
Right, so committing to you and elevating your health and maybe applying what you learn is, individually for you, you're a really good case study, right? You're available to you constantly. And whatever these concepts that you're learning in school, applying them to yourself really is not a bad idea, right? To kind of get familiar with it and then to model something, then to understand it better, and then you'll be able to be more effective with other folks when you do that. So yeah, being mindful of your own wellness, right? Multidimensional wellness is good, and committing to that. Okay, hi, yeah.
I was just gonna say start with my family first, because like you said, when you're telling your mom like you should listen to the doctor, or maybe the advice that they're giving you is valid, sometimes they're the hardest patients.
Oh yeah.
So if we can deal with our family and make those changes within the home, then it's gonna be a lot easier to translate that to the community.
Yeah. So practicing those communication skills, right, and health education pieces with your families, like good, fantastic. What else? What else? Yes. Hi. Volunteer. Absolutely. That is such an amazing thing to do, right? There are community organizations that are focused on promoting health, and that you can find and volunteer and give some of your time to that. While again, and when you're volunteering, you're learning as well, right? You're interacting with other people. You communicating with them. You're sort of learning how to go about saying something that will be, that lands well, right? And how to sort of position something for somebody. So that's fantastic. Yeah, commitment to volunteer. What else? Come on, everybody has to go, so might as well. Yes.
Keeping up with competency, so always trying to find ways to learn more.
Yeah.
And moving on, or you can move over that to inform not just patients, but also other civilians.
Yeah, absolutely. So keeping up the competency, learning is important. Learning for you guys is absolutely important, and really truly committing to it. And also, I would say this, in order to learn better, you got to ground it in something. You have to understand the why you're learning a particular thing, right? Because in a vacuum, it may not make sense to you, but if you start mapping out, and faculty are there, they're really great in helping you to connect those dots. Because this particular piece, this is how it builds this, right? Something, a higher level of competency and so forth. And so that's figuring that out and doing that's fantastic. But commitment to learning, that is your number one job right now. I mean, some of you may be parents, and some of you, all of you probably work, right? Everybody works.
I would say critical thinking.
Yeah.
I listen to patients, and then let's say the physician says, "Oh, you need to give your patient this dose or something." Speak up.
Right. So being, our at the core of the practice itself, right? It's the advocacy for the patient. But you have to know your stuff, and B, you have to process, you have to reason through everything, right? So it's making sure you're processing orders, right? And you're connecting the dots again to something that is this really correct here, right? Because everybody's short on time and errors do happen, and so reasoning whether or not this is the right thing to do right now, and you may know more about your patient right now, than a doctor may, right? Their condition now, today, in this moment, how are they doing? What's happening with them? And yeah, so applying that kind of, you learn that reasoning, you can apply it anywhere with anybody, right? You don't need to essentially, have a job yet of a nurse, but you can learn to reason through things while you're studying and learning and all of this. So yeah, the critical reasoning is absolutely important, and which means if you start reasoning through all of this stuff, and I help you with a few things, right? I gave you sort of a couple of paths on things that may seem so disconnected from healthcare, right? Like climate. But that's what critical thinking is, and reasoning through things and saying, okay, but how does this connect to that? So yeah, very good. What else? Yes.
So I would say, kind of building my team. So going to nursing school is kind of one step in my plan to provide for the community.
Yeah.
And so I have a team of people that are like-minded. So, we can spitball with each other, and we know that we want to create this system for our community. So
That's awesome. Yeah, finding other sort of like-hearted, like-minded folks that want to drive change, right, and want to. So banding together is important. There are nursing associations that are. There's a student nurse association that's available, and Nightingale has a chapter of that. So joining that, right, because you do get resources from that, and you do get community, more extended community from that. But yeah, it's a collective, right, a collaborative, cooperative sport. This thing that we are trying to do together. Like we have to connect with other people, because alone, I mean, you know, there's only so much that you can do alone. But together we can drive incredible outcomes. There's, I forget her name, but very famous quote that goes something like this: never doubt the sort of the outcome and the change that a group of very committed people can drive, can achieve, right? So it's there. All right, what else? What else? So and not try, right? Like not whatever, but do, like commit, right? So like, oh, I would say, don't say, just do. Yeah, it's like Yoda, you know. No, try not, do or do not. There is no try. I mean, those of you who are Star Wars probably are like, I don't know. I don't know who Yoda is, but he's a Mandalorian. Anyway, for some of you, it'll be a good reference. Okay, well, who else? What else? Let's do it. Come on. Yes.
Also going off the group as well too, you can support each other and push each other to kind of educate or
Accountability partners, right? And it's like, I want to doom scroll. It's like, that's what I want to do right now. And then if you have an accountability partner, they'll be like, nope. And then vice versa. Like when they get to their doom scrolling, you can be like, pulling you out of it into like the world of the reality, which is like here, not here. So yeah, accountability partners in education and learning are very, in exercising, in doing anything, are very, very, like you're committing to anything, find an accountability partner, whoever that will be, you know, like 1, 2 folks that sort of like, okay, we're gonna do this for each other and push each other and remind each other and not let each other off the hook. It's like, but this one time, nope. So that's good. What else? Huh? No? Come on, something. I will prophesize, no?
So I do work in the healthcare community as well. So I would say maybe promoting more like health promotions. We are still trying to figure out ways to help patients like to come in like for their physical checks.
Yeah, exactly.
Checks, you know.
Getting them in is like half of the battle.
It's hard. So I think that's really important to help the community understand like the importance of just physical checks, just annual physical
Awesome.
checks.
You're gonna have, is everybody in the BSN here? Okay, so you're gonna have a project at some point, a community project, and that would be a great one. Figuring out, like for your community, how to get people in. And there's, you know, there's systems and tricks and whatever you can do to like lure them into a physical. Okay, fantastic. How about?
I would say probably just peers, my coworkers, just whatever knowledge I've
Parting the knowledge and educating them and
Yeah.
saying like, hey, this is, and it's important for all of us, right? Like that's not just for you, it's all of us. All right. What are you committed to?
Probably volunteer also, because I graduated as a medical administrative assistant.
Okay.
So I go to clinicals also, and we have like volunteers where we can take like blood pressure.
Awesome. So volunteering, helping out and stuff. Fantastic.
And also right now I work as a quality assurance for home health.
Okay.
And yeah, I'm the one reviewing all the checks for the patients, and I can see like where they don't see.
Gotcha. Okay. So yeah. So volunteering and then kind of, sort of like seeing what you're seeing and then trying to connect the dots and connect it to your learning and all of this. All right.
I would kind of do the same as like everybody else, like educating my home and my family like everything I learned, because those are the hardest patients.
Yeah, it's true. It's true. I'm like if I can talk mom,
Yeah.
you know, the path to mom. I mean, yeah, then you can totally. Oh.
She's a nurse, so she's.
Oh, your mom is a nurse? Yeah. Oh, wow, yeah. Okay, then, you know, gain wisdom. Okay, fantastic. All right. Who else? You guys over there, yes.
I was looking at closing the gender gap in the profession and reaching those populations in the minority.
Awesome. Like gender gap, I mean like, and what it's going to take is men talking to men and talking to boys. Like in the middle school, in like early high school, because people usually make their decision as to like what they're gonna go into somewhere between like I mean it starts as early as 6th grade and to about 9th grade. So like that population is really important. And so yeah, going and you know like connecting with the local school and saying, hey, can I come in and talk about like my school and like what I do and bring the goggles, you know, and it's like, hey, can you check that out, right? Like, isn't this cool? Absolutely, yeah, that's a good one, and it is. It's gonna take a bunch of men talking to men and inviting them into the profession and you know, and just saying, look, there's a lot of heroism, right? And boys are seeking that. Like, I want to be a superhero. You can be. Look, you for real can be a superhero in nursing, and so and not to you know let all of the women as like superheroes as well. Fantastic. Hi. We have.
Yes.
Yes.
I would mostly say what everybody would say, volunteering with the community, like how you just said with the school. A lot of schools still do DARE, and it'll be nice to have a nurse there educating the kids, letting them know, hey, drugs aren't good. And I also
Exactly.
Yes.
Drugs are not good.
And I also, like before I started in school, I was blogging, and I like watching a lot of the nurses that educate.
Oh, awesome! A blogger, yeah. There's a couple of famous ones, yeah. And there's Blake, and then there's like there's some folks. All right, who? I think you're the last.
I agree with also educating my family first, even myself.
Okay, awesome. So applying what you learned to yourself and your family, fantastic. I'm sure there's a bunch of ideas out there in the cyberspace as well. Now, whatever it is that you said, saying it is not enough, right? You have to commit to it. So you've made the choice, right? Like, okay, I've made the choice, I've whatever. Then you commit to it for real without sort of backing out of it when it gets a little tough, right? Because we love to do that. Oh, but I'm gonna give myself a pass. No, commitment is a commitment is a commitment. Not like some marriages, you know, like, we'll try it and then, till death do us part. Well, I was just kidding, it wasn't Vegas. So yeah, commitment has to be real, and then commitment has to be followed with actual doing, actual action. Because again, commitment without action is just a dream. It's not real. So do that, all of you here, all of you out there in cyberspace, commit to making this better. Your community's better and healthier. Our healthcare better and outcomes of it, you know, better, and the population's flourishing and making it more cost-effective, therefore value-based. Commit to your learning, commit to gathering with others, and driving these changes forward. This is important. You are important in solving. Absolutely solving these issues. And look, if you guys like, if you get this spark and you drive it forward, I then feel good about the future of it, the future of nursing, that's you. The future of this profession is you, and thank you for being here, and thank you for engaging, and those of you in cyberspace, thank you for engaging and listening, and hopefully, you know, from here on out, you will take action and drive this flame that Florence Nightingale, you know, lit up a long time ago, and then we continue carrying forward, continue carrying it forward. So thank you, and flame forward.